Okay, today we will talk on bone healing. So, before I start discussion on bone healing, I just want to, explain some concepts on embryology of bone, because the most of the healing processes are like development of bone. So we'll have just a few concepts on embryology. So usually bone is developed from the mesoderm, which gives most of the connective tissue and bone. So whatever tissue is developed from the mesoderm are called mesenchymal tissues. Okay. So there are two types of bone healing. One is the endochondral ossification, and the other is the intramembranous ossification. Okay. So most of the bones are by the endochondral ossification, except skull, pelvis, and other flat bones and clavicle. So apart from these, most of all the bones are by the endochondral ossification. What exactly happens is there is an cartilage enlarge. So this cartilage is having a lot of chondrocytes. Okay. The blue cells with collagenous matrix. Okay. So in the center of the bone, in the mid diaphyseal region, there is a hypertrophy and proliferation of chondrocytes which occur, and this hypertrophy, the noteworthy thing is cartilage tissues are always avascular and aneural. Okay. So they get their nutrition from the diffusion from the extracellular matrix, which is loose, which surrounds the chondrocytes. So when there is an hypertrophy, so it fills most of the area and the amount of extracellular tissue is less. So at this point there is an increased collagen 10 and fibronectin content in the extracellular matrix. So this favors the calcification of the extracellular membrane. So once the extracellular membrane gets calcified, there is a cutoff of the nutrients to the chondrocytes. So the chondrocytes will go apoptosis to form a lacunae in the calcified extracellular matrix. So this will be now it is no more a cartilaginous tissue, so this is invaded by the blood vessels around, and these blood vessels, they fill in these lacunae, and the lacunae will also increase, and the blood vessel which is getting blurred will also get bone forming cells which are mesenchymal mesenchymal stem cells, osteoblasts, and other osteocytes and other monocyte macrophage lineage cells and other hematopoietic cells. So these will come and start staying in these lacunae, and the mesenchymal stem cells will eventually differentiate themselves into osteoblast, and the osteoblast will start laying an osteoid. Osteoid is the non-organic matrix of the bone. Okay, so here I just want to interrupt and tell these two things. Ki bone is made up of an organic phase, and a mineral phase, okay. So this mineral phase is mostly occupies around 60 to 70% of the bone volume, and it is made up of calcium and phosphorus. Semine means a poorly crystalline hydroxy apatite. The organic phase, which is the other phase, is 90 to 95%. It is consist of collagen type 1. Okay, it is consist of collagen type 1, and the rest are some membrane bound proteins and some signaling proteins and other proteins like osteocalcin, osteopontin, metalloproteinases, and other proteins. Okay, so this part which is formed, upon which the mineralization happens, this is called osteoid. Okay, sorry, this is not non-organic, this is the organic matrix of the bone. So the non-mineral part, the unmineralized, which is going to mineralize, so that organic phase made up of mostly of collagen is called osteoid. So this formed osteoid will eventually get mineralized to form bone. Okay, so this is how the endochondral ossification is taken place, and the perichondrium, which is around the this cartilage, the particular perichondrium which is in the mid diaphyseal region is eventually converted to periosteum, and in the mid diaphyseal region it is called periosteal collar, which has an abundant mesenchymal stem cells, osteoblasts lined up inside, and that will form something called as cambial layer. This cambial layer retains mesenchymal stem cells which can differentiate into osteoblasts and chondrocytes. It can also differentiate into adipocyte, which is not of much importance, but this conversion into an adipocyte it is important in forming the medullary canal of the diaphysis. So whatever I told you happening in the mid diaphysis, so the calcification which has formed is called the primary ossification center. Okay, So this is the primary ossification center, which of most of the bones will occur by the before the child is born. So I mean to say the primary ossification centers of most of the bones are there at the time of the birth. So the other mode of ossification, or the other method of ossification in children is the intramembranous ossification. Here there is no cartilage anlage. So the local mesenchymal stem cells, which are gonna form the skull bones, pelvis, flat bones, and clavicle, they directly convert themselves into osteoblasts, and these osteoblasts they some kind of a cluster themselves and start putting an osteoid matrix. They start throwing osteoid matrix to form a osteoid. So this kind of ossifications, and initially there will be a bony spicule, then on the surface of which the additional osteoid is laid down, and ultimately it is mineralized. So this is the intramembranous ossification. Okay, so and if you carefully see the microstructure of the bone, initially it starts like this. There is a collagen helix type 1 fibers, upon which there is a mineral which is attached all around. Okay, and this is the primary block of the bone, that is the collagen type 1 along with the hydroxyapatite. So these fibers, they join side by side to form a kind of a multiple palisaded pattern. So these multiple fibers, they orient themselves in such a way that they ultimately lead to have osteoid formation. So we'll see that. So what this happens is they not just stay upright like this, they bend to an angle. Why I'm going to tell that later. Okay, so initially if you see the osteon, so the arrangement of fibers along with the hydroxyapatite is like this. And above which the next layer, there is a lamellation between one bundle of fibers to the other bundle of fibers, and they are at an angle. The next bundle which surrounds this, the next lamellae, is somewhere like this. The next one is like this. So if you see the cross section here, it looks something like this. There is a Haversian canal, there is a central canal around which there are multiple lamellations. Okay, and in between there are lacunae in which the osteocytes reside, and they have something called as canaliculi. So the purpose of arranging in a different angles is that, so if you take a block with the oriented fibers like this, of course they are very resistant to the compressive force, but they are weakest in case there is a tension force or a shear. So if the arrangement is, different in different planes, so the ultimate construct makes the all kind of forces acting on it to be the strongest to the one, at least to one bundle of fibers which are oriented perpendicular to that direction of force. Okay, so the this primary functional unit is called Haversian system. Haversian system. This is also called as osteon. Don't confuse with osteoid. Osteon is a Haversian. It's nothing but a Haversian system, which is the primary functional unit of a compact bone. Okay, so again, so yeah, so if you take a femur, this is the medullary cavity, this is the cortex, and there is a spongy bone here, there is epiphysis. This cortical bone is called the compact bone. The spongy bone is the trabeculae in the medullary canal. This should not be confused with woven and lamellar bone. Woven bone is that preliminary bone where there is an haphazard arrangement of the fibers and the mineralization. Lamellar bone is that one which has a proper Haversian system with the uniform arrangement of the osteocytes and the collagen fibers and the hydroxyapatite surrounds it. So this is a lamellar bone and this is woven bone. Okay, so I laid so much of this basic things because these are important when we discuss the bone healing. Okay, so come to the bone healing per se. So I would like to divide this into one which occurs in case of relative stability, and the one which occurs with the absolute stability. Okay, so relative stability will include all the non-operative conservative methods and some of the operative methods. the absolute stability is one where there is a compression at the fracture side. Okay, so so we'll come to one by one in detail. What happens in relative stability is ki, so before that I just want to tell this a funny story ki all our bone forming cells, mesenchymal cells, osteoblasts and all are like Spider-Man. Yes, they're all Spider-Man. Because what happens is ki if you have a if you have two blocks like this and the distance is very less, so a person can just step over and he can cross this gap. So the same thing, if there is a too much of a gap, then this person is a Spider-Man. What he does, he throws a web to the other building and then he travels. Then he reaches the other building. So this is what happens in absolute stability. Okay, this is what happens in relative stability. So in relative stability there is a gap and there is a intermediate tissue formation, which aids the repair of the bone. So here the gap is so less that the osteoclast can easily jump over and cross over this gap. So the normal diameter of an osteoclast is usually 100 micron. So that amounts to 0.1 millimeters. So if the gap is around 0.1 or 0.2 millimeters, it ranges to 100 to 1 milligram. So an osteoclast easily rolls over onto the other side and behind which the bone forming cells will follow. Okay, so this is the absolute stability. We'll go on in detail later, and this is something called as relative stability. This analogy is for relative stability. Okay, so yeah, so coming to the relative stability per se, so I just want to clarify this one very I don't know ki you must be knowing, but many of the people are confused that they think endochondral ossification means repair with callus, and intramembranous is repair without callus. That is direct bone healing, which happens in absolute stability. No, this is a wrong concept. Because intramembranous ki, of course there is no intermediate tissue formation directly from mesenchymal cells to osteoblast formation of osteoids, which is not the case how direct bone healing occurs. Okay, so once I explain absolute stability, you'll know it. So before that, I just want to tell that I find this as a wrong concept, and I have multiple references for that. Okay, so what happens is ki in a relative stability, the healing occurs with both endochondral and intramembranous. Both will occur when there is a healing followed by a fixation or a non-conservative methods, which are like a relative stability. So how this happens is, if you take a bone which is fractured here, it has a periosteum which is torn, okay. But if you remember, the cambial layer has, first of all, there is a lot of blood supply to periosteum, and there is an endosteum also, okay. So this periosteum has a lot of mesenchymal cells and osteoblasts and other bone forming cells, which will directly which will directly get differentiated into osteoids, and they osteoblasts, and they lay their osteoid, and here what we are observing is the intramembranous ossification. Okay. But this happens from the periphery. Once this starts occurring, and of course there is a hematoma formation, all the inflammatory mediators are poured into that, there is a formation of fibrin, and there is a activated local mesenchymal cells, there is a pluripotent stem cells from the bone marrow, and a lot of other things which come into play here. And here there is a formation of a cartilage enlarge, and these and at this point, whatever the pluripotent and the multipotent mesenchymal stem cells, they get converted into chondrocytes, and they form a cartilage enlarge. And again the same story, there is a hypertrophy of the chondrocytes, there is a collagen 2 and collagen 10 and fibronectin content increased, which increases the extracellular calcification, and this calcification leads to apoptosis of the chondrocytes, formation of lacunae, and once there is an ossification, when it is no more a cartilage, there is an invasion of the blood vessels, and they carry a lot of bone forming cells, and on the collagen formed, there is a already formed collagen on which there is an extracellular calcification. Then now the osteoclast comes, and that resolves these extracellular matrix of cartilage which is calcified to form and resolves this, and to form the osteoblast, its own osteoid, which eventually has a collagen type 1 which is required for us, and that will get eventually mineralized and forms a bone. Okay. So in most of the bones, especially in the diaphysis, the relative stability will have both types of ossification occurring simultaneously in the process of healing. So the other biomechanical things are the maximum strain, that is the change in length to the original length upon force, that how much displacement is there upon the physiological load, that is called strain, that is maximum at the ends. So once this periosteal mesenchymal cell induced intramembranous ossification starts at the periphery, the strain will significantly come down, so that the endochondral ossification of the middle part of the bone is happens easily, because the coming angiogenic and the small budding vessels, if there is a lot of movements like this, it is difficult to negotiate into that moving thing. So once we decrease the strain by the endochondral by the intermembranous ossification of the periosteum, underneath of the periosteum will decrease the strain, and that will aid in the invasion of the blood vessels and the whatever process I have told. Okay, so the rest of the things, the soft callus formation, hard callus formation, and the remodeling. And you should remember it is kind of a continuum. So it is not distinctly that stage 1 followed by stage 2 followed by stage 3. It is not like this. So there is by the 3 to 5 hours of the fracture, there is a huge hematoma formation, which starts the process of soft callus formation by around a day or so, which peaks by the end of a week, by 7 days, and then it starts coming down, because by 1 week there is a formation of hard callus which peaks by around 2 to 3 weeks, and it goes down, and this almost may take around 3 months, and by 3 months or so there is a start of process of the remodeling, which may take around 5 years. Okay, which may take around 5 years. So this is kind of a continuum which happens. Okay, so now we'll look at the other mode of fixation, that is absolute stability. The healing in this case is by the direct bone healing. Okay, so this direct bone healing, it is nothing but an osteonal remodeling which happens otherwise also to maintain the blood calcium levels. So what happens is we have a compression at the fracture side. Okay, so most of the gap is obliterated by the compression. Okay, so at this point of time, so the osteoclast, if you take a small part here, of course there is a Haversian system there with the collagen fibers. Of course they are arranged in a twisted manner. For the simplicity, we assume like this. So in the surface there are osteoblasts and some osteoclasts, osteoblast and osteoclast. They come in the center and they form something called as a cutting cone. So in this you have a leading edge which is formed by the osteoclasts. Okay, and these will resorb the bone, which is followed by this is the vessel, central canal, which follows it, and you have a surrounding osteoblasts which lay their osteoids and eventually that will get mineralized to form the Haversian system. So this is how it goes. And the rolling over of an osteoclast is not a big thing, it's not a difficult thing, because the gap is very very small in cases of absolute stability, because of the compression. So easily these will roll over, and they carry a bone forming osteoblast behind them, and these will form an osteoid, which will eventually get mineralized, and uh, they ultimately form into a proper Haversian system around this central canal. Okay, so you can say, of course, there is a group of osteoblasts which are laying directly their uh, osteoid. So why it is not an intramembranous ossification? So for that, to answer this, I just explained the whole process. Ki intramembranous ossification should have a mesenchymal cells which get converted to osteoblast, and that will lay the osteoid. But here in this case, the osteoblasts which are there already are laying the osteoid matrix, and there is no formation of a spicuole, and the ossification on the surface of spicuole. So this is nothing but an osteonal remodeling which happens at any point of time in your body to maintain the blood calcium levels. So I would separate it from intramembranous ossification, and I will classify it as a direct bone healing by the osteonal remodeling. Okay, so for the completion sake, I'll just say one or two words. Ki the two phase system what we have is the best system to handle the stresses, because one is very stiffer, that is the mineral phase, and the other one is a less stiffer one. So this interplay between these two phases will make the bone more ductile, so that it doesn't easily break. If you just make the mineral content more, so bone becomes more brittle. That's what happens in the later stages of the Paget's disease. So that is also not good thing. And the other extreme is the deficiency of the organic phase, that is the collagen part of the phase, so which typically happens in osteogenesis imperfecta. There is an amino acid substitution in the alpha helix of the collagen type 1, collagen type 1. There is a cal1 and cal2 genes. So the other, so ultimately what happens is there is a deficient collagen type 1 synthesis. So there is a disturbance in the two phase system, which makes the bone very very easily breakable. So the OGI babies can have an intrauterine fractures or a fractures during birth canal, or later ages, just a walking child can have a lot of fractures. Okay, and other thing is key in the inflammatory phase, there is a lot of cytokines and other molecules, paracrine molecules, which involved in the bone formation and other things. The two things which I want to mention is, one is the fibroblast growth factor 3 receptor, and RUNX 2 molecule, which is produced by the pluripotent and multipotent stem cells which is required for the osteoblastogenesis. Okay. The problem with this, I would say the action of fibroblast growth factor is very important in signaling and for the bone formation. So the problem with that receptor will cause a problem that is seen in the achondroplasia. They have a problem with fibroblast growth factor 3 receptors, and a problem with runs to molecule will lead to something called as cleidocranial dysostosis. So there is a problem with osteoblastogenesis, and since the osteoblasts are primarily very important in cases of intermembranous ossification, because there is no cartilage enlarge, there is no other way for the calcification. So the most of the intermembranous ossified bones like clavicle and cranium are involved in this disease. Thank you.